Welcome to DocPod. Hear Health.
Thank you so much for sharing some of your time with me. I'm here with Dr. Amy Schiffman, who is the CMO of HealPros, as well as podcast host and host of the podcast Mastering Medicare. So thank you so much for your time. Thanks for being here.
Absolutely. Happy to be here.
Happy to have you. So on that last note, Mastering Medicare, if you can, tell me how to do that.
Okay. So we are available on all of the places where you would listen to a podcast. It is called Mastering Medicare. I have a co-host, Dr. Alex Moseni, and we basically unpack the healthcare ecosystem blueprint. Like, how would one understand the A, the B, the D? And we have an amazing group of people that we interview who are helping people, primarily C-suite, investor, senior serving professionals, but also accessible to consumer, basically just unpacking how Medicare works. How do people get paid? What's what? And we've just had a really great time turning something incredibly dry into something super funny. So,
well, I'm excited to give it a listen. I'm curious as well because I've got my own personal experiences with Medicare. I won't go into gory detail, but some of them have not been so great. And with excessive oversight and sometimes what may seem to be aggressive, maybe not interference, but I don't even know what I'm trying to describe because I'm trying to walk on eggshells here a little bit.
Yeah.
But
it's like there's a utilization review that happens in some levels of Medicare. I mean, I can just give you a little perspective is that you're probably referring to some, and again, I will walk on eggshells too. There's Medicare Advantage, which is essentially privatized Medicare. And that is really managed by utilization review committees and all sorts of, humans behind the scenes that are helping to make decisions. But if you had been accessing care through the original Medicare side, you can just keep on going. It's kind of like the gift that keeps on giving in some ways, plus minus on that.
Right.
But the big distinction is between original Medicare and Medicare Advantage. You're probably speaking to something that happened while one of your loved ones was under, because Medicare is insurance, it's not care, but they become really intertwined on the Medicare Advantage side.
Well, and as you talk about, how the podcast is directed towards C-suite executives, towards investors, but business owners, et cetera. But how is it that you're explaining how to navigate Medicare to them, as opposed to a user or somebody that has a family member that would? What's the delineation or differentiation there?
So we're really interested in how money flows. So I'll just as like a point of interest, I became really interested in this system of medicine when I was a resident, and actually started a business of medicine class that I tried to teach to the medical students and to other residents of what is it that we're doing that makes money come through that door? Like, how do we tell the payer, the people that are going to be paying us, what we did and why? And then how do we get paid in certain ways? So I also took a great interest in geriatrics. Even though I was an emergency medicine physician and I did my training in emergency medicine, I became really interested in the care of older adults. Tried to help them to sort of navigate what I thought, even in the original Medicare side, incredibly complex. There's a Part A and then there's a Part B, but even under Part B, you don't even get paid the whole amount, and Medicare sets the rates. Then you got to get a secondary insurance. And how do you access things that you might not know you've been paying into the system this whole time to get? So that was sort of like how this all evolved. And then about 15 years or so, I started a house calls practice for frail and homebound elderly folks. And it grew pretty large. We were taking care of, several thousand homebound seniors who basically met the criteria for being homebound, which is about 5 to 15% of all Medicare beneficiaries. And this was in the DC metro area. And in doing so, I realized I had to become a systems engineer because I had to know, like, when could I bill Medicare and then also get other services? And then when was Medicare not going to pay? So I had to kind of interpret all these vectors going all over the place. So weirdly, I also like to read, and I like to read Medicare like how Medicare works. And I read their Medicare, like learning network stuff and new codes. And I got all excited about all these different things. And over time, I kind of synthesized all of this into basically a learning module that I would give to nurse practitioners, PAs, and doctors who came to work for me, including all of the administrative staff. I wanted people to have, if not 100%, but 80% of the knowledge that I had, so that everyone wasn't like, I don't know if you can get a hospital bed in your house, and I really don't know how to do it. Like, I wanted to empower everyone who worked for me. So over time, I was giving this talk and giving this talk and giving this talk, this like, what does the healthcare ecosystem look like? How does money flow? How much money do you need to save in order to, pay for as you age in place? And I kind of got the hook of one of my colleagues, Alex Moseni, who's also the emergency physician. And he was like, oh my God, I've never seen all of this put together in such a synthesized way. So we decided we would start a podcast right before COVID, because like everyone loves a pre-COVID podcast. Uh-huh. And so we then sort of like started spelling this whole thing out. And the podcast actually became pretty wildly popular with the MBA types, like Stanford. Some of my colleagues from UPenn would call me and be like, oh my God, this is finally someone explain this. So you don't get this big, broad, strokey, like part A is for hospitalizations. You actually like dive very deep into what it is that's actually getting paid for, and what does that EOB that the patient receives really look like? And then also, where are the gaps in the market where somebody could come along, some very smart entrepreneur could come in and make changes either with digital health opportunities, care delivery opportunities, those types of things. So it's just become it got a life of its own. This talk that I started giving turned into a podcast, essentially. So that's where that went.
Well, and it sounds extremely valuable on both sides of the table, right? Because if you don't have a roadmap, whether you're an entrepreneur or a business person, or especially maybe as a person who is aging, maybe not as gracefully as they would like to, or post-retirement, as you mentioned, post-retirement.
Post-retirement, I can get into that.
If you don't have a plan,
right,
then you have no idea what is or is not going to cost how much or how little. And then all of a sudden you could either be out of money or not getting the correct care, and just a litany list of other things that could go wrong. And so, you're checking off the boxes of all of the things that need to be done and then some for somebody that is at that state in their life. So that's awesome.
Yep. I mean, I think it's important to contextualize sort of, and I have all these Amyisms. Everyone goes, oh, that's an Amyism. That's an Amyism. So I kind of developed
Give me a few.
I sort of developed a way of thinking about if you had and this is really spreads more across, when I talk to startups and say, like, where are you entering the market? Where's your go-to-market strategy? Where does that need to be focused? That's sort of where this came from, this concept that I'm about to describe. But I talk about things like, first of all, 65 years and older, for the most part, you're in Medicare. But there are 60 million Medicare beneficiaries, half of them in MA, half of them in original Medicare. And there's a good chunk of folks who are also dual eligibles, which means they have Medicare and Medicaid, and some of those are under the age of 65. So that being said, there's about 60 million people that I'm often talking about. And I've divided the world into 4 little buckets. There's pre-retirement, there's retirement, there's post-retirement, and then there's post-retirement. And I have focused most of my career as a house call provider, post-acute care sort of subject matter expert in this post-retirement space. The post-retirement space is about 24 months on average, I would say. People who are going into assisted living, who are starting to need help at home, who may not be making as many decisions for themselves. This is a time when, there's a sort of a wind down. People aren't thinking so much about wellness in the same context and longevity in the same context. This is a really critical time when navigating the healthcare ecosystem becomes so core critical. So when I'm talking to business owners or people who are in the startup space or C-suite folks, and I'm like, where's your go-to-market? Or what are you talking about when you want to talk about an individual group of people who are over the age of 65? Are they pre-retirement, retirement, post-retirement, or post when their healthcare is really so paramount to them.
Right.
And I think it really helps because that's where the complexities of how the medical interplay is happening. How do I get private duty? How do I get home health? What's the difference between private duty and home health? How do I get durable medical equipment? What is hospice? What happens if I get hospitalized? Oh my God, I'm going from the hospital to the nursing home. Oh geez, I'm getting discharged. Where do I go? What is the difference between assisted living and nursing home? All of those things come up all the time. So I take a lot of pleasure in sort of simplifying some of these concepts for people. Because when I did house calls, this is what I did. I watched people sort of march through the healthcare system, but in the very most complex ways, with lots of medications and lots of medical problems, and not a lot of money sometimes.
Right. And as they're doing that, it's a maze that you can't see from the top, right? And so you have no idea where you're going. You have no idea what to budget. You have no idea what direction is up. And I've been through that a couple of different times on a little bit of a maybe from a cursory perspective, but my grandparents.
Sure. Everybody starts to see it at that level, either their parents or their grandparents. Suddenly you're like, wait, you're sending mom home? You're sending grandma home? Like what am I supposed to do? And
it doesn't become important until it does. And until you're exposed to it or you need it, because personally, and I can only speak for myself, but I never thought ever about any kind of home health care, palliative care, nursing home, any treatment like that, because why would I? I was, 25, 26. And then once you get that phone call or understand that, a loved one is going through this and fortunately being helped, by members of my family, my parents, et cetera. But you start to think about it like, okay, I need to make some phone calls. I need to call. This isn't getting done correctly. I'm going to go make sure that it does. And I didn't know what I was doing. I was just angry. So
true that. And I can speak to that. I think that we all, let me take it back a step. One of the things that I became really shocked at is as I began my self-discovery, I was an ER doctor for many years. And then when I started my house calls practice, it was like a whole new world. It was like, wait, this is what happened when I discharged patients? Like you become like, sorry. And so you begin to realize what my colleagues, my physician colleagues did not know. Discharge planners from hospitals are just not, they're wonderful people, but you can only know so much. So I have actually identified tremendous gaps in the system in terms of what even the professionals know. So I have given this same talk that I always give, like I'm sort of not really, but it almost sounds like I'm what do they call it? A one-trick pony in some ways. But I always say to everybody, I know you've been doing this for 20 years. I guarantee you I'm going to tell you 3 things you never knew before. I guarantee you. So discharge planners don't always know all the resources that are in a community because how could they? Right. My physician colleagues don't understand anything outside necessarily of their hospital, if they're hospitalists. They have some knowledge, but you don't know it until you do it. So
operating in kind of a vacuum there, right?
Absolutely.
Because why would you?
And we're all guilty of that, right? Like I can't go into a hospital anymore and know how to navigate that. So we all have our own little subspecialties. I used to call myself a house callsologist. And then I started working with some tech folks and trying to bring new technology. So I became like an implementologist. So there's all these fun little words that you start to develop. But there was something that you said that really struck me. You said, like, I'm only in my 20s. Like, I don't really know about this. I think that the education, like we're missing something, in our education at the high school level, in college. It's like how we're going to actually like do stuff when we're grownups. They don't tell us how to pay taxes. This is like back to shop class,
Exactly, right?
Like little bit of this
or home ec as it once was.
Yeah.
I'm not old enough for home ec. Just let me not age myself that much. But
I'm definitely not old enough for home ec. I don't even know what that is. No,
yeah, exactly.
What?
Right? Well, then that's the thing too, is like, when it's too late, it's too late, right? And if you don't know what you need to at that point, then you are scrambling, you're running around, and it's emotionally charged. It is not data driven. You're not actually doing what you may need to do. You might get lucky, lightning might strike, but if not, and you're like, you said 60 million people are on Medicare or some form of it, one of them. So related to those 60 million, there's 7 degrees of everyone to Kevin Bacon. So I'm fairly certain this affects every American.
Every American.
So with that said, you're right. There needs to be education. What does that look like other than the Mastering Medicare podcast?
Sure. So I think, one of the things is that, health systems need to look deep to the people that work for them, because if they want, health systems are now like looking at, how do I make sure people don't come back to an expensive type of care? Right? Like, I think if we look at where the health system is going, and has been going for some time, depending upon either you're on the original side or on what I call the MA value-based side, the whole goal here is to keep people out of expensive and potentially unnecessary high levels of care. I mean, we can talk about prevention, and that's a whole other conversation. But unless you understand the navigation of the healthcare system, you just walk around bumping into walls. Should I? Yep. Oh, no. And we all say to ourselves, oh, well, we don't want to go back to the emergency room. But if that's all you know how to do, because you didn't know there was a way to go potentially straight into a nursing home, there are ways to do that. You didn't understand that maybe you could ask your primary care doctor to get a house call doctor to come to your house. So there's all sorts of things that if you don't know it's on the menu, you don't know it. So I would encourage people who don't really have a fundamental understanding. I mean, obviously, I'm going to direct you to my podcast because we're fun and funny. Right. But I'm available too to, from a consulting perspective. I consult for health systems, trying to help just the hospitalists alone understand what the post-acute space looks like, because that's where the cycle comes back. That's when patients are coming back to the hospital for things that they may not have needed to do so for. The complexities exceed the ability of any regular person, doctor or not, health exec or not, discharge planner or not, business owner of a senior serving type of business like private duty. There are, 72% of all people will eventually need some sort of care as they age. Many of them are accessing that through either Medicaid programs where they get private duty aids in, or private pay. It's an enormously costly industry. Very and much. People at the end, and in that post-retirement place, when people get there and adult children are often coming in to sort of like manage it, there's this like aha moment, and it's usually, followed by maybe even vomiting into your mouth, quite honestly, when someone goes, hey, it's $38 an hour to have somebody be awake and in your mom's house. And you're like, wait, what? Medicare doesn't pay for that? Yeah, like Medicare just does not pay for any of these things that we assume is going to happen. Right. Medicare,
I paid into it. I paid insurance, all of these things, and it's going to cover. Well, actually, no. And nobody looks at that. I mean, when I say nobody,
actually,
not
no,
many.
Exactly. And actually, no, like it's not.
Right.
It's the aha, scary moment that people come to. So I think to answer your question is like, how else can people get education? And I think it's really reaching into your individual communities and trying to find somebody who's a navigator in that space. There's a whole group of people called aging life managers, geriatric care managers. I would say that they bring to the table an enormous number of resources. Healthcare is super local, and post-retirement care is super local. Mm-hmm. So you really need people who understand how to navigate that. Again, I give the same, one-trick pony talk to geriatric care managers, and I'm always like, you will learn 3 things in this that will change how you do your job. So, I think that that's how I would help people who don't know what to do next, is look inside of your own communities. There's often commissions on aging, departments of aging. Sometimes they're sparse with information, and sometimes they're sparse with resources. But yeah, it's really tough. It's really tough.
Well, I think it's also just getting people to start asking the question of kind of the what now or what if, maybe, because sure. Again, when I was much younger, 15, 20 years ago, you just don't think about it. So I'm uneducated, but I'm not even having that thought cross my mind of taking care of aged parents, grandparents, family members, whatever it may be, right, until it happens. And when it does, you can ask the question then, but there's no preparation. So, how do we get just the idea? Like, how do we start turning on light bulbs over people's heads about
Sure.
this.
Sure. I think you bring up a really interesting point, and I'm going to take what you just asked. I'm going to extrapolate even farther down the line. I've recently become involved in helping some companies in what is known as the death care industry, which is essentially the funeral home, crematorium, cemetery industry. And I recently gave a talk, and what struck me about the audience is that there's a very similar set of problems that happen in the death care industry. People don't pre-plan. I mean, even if there's a discount, they don't pre-plan, right? Like, hey, it's like BOGO on funerals, but like, not to be
What am I going to do with this extra urn?
Yeah, totally. We'll throw it in. But people don't pre-plan. There's very little pre-planning. Only 20% of people pre-plan for their funeral.
Mm-hmm.
Okay. So then you take that back a step and you say, well, how many people have their wishes known to their family of what they would want to do at end of life? At the time most people enter hospice, only 20% of even have advanced care planning. Mm. So there's a certain denial in that conversation that is really, really hard. There's emotion in it. The adult children are often like, Mom, just say it. Mom, just tell us. Dad, just tell us. Just tell us what you want to do. But these are individuals and they're humans. And, the doctor in me is always this is patient choice. Right. People have to be able to have that discussion. And people need a very caring way to bring up that discussion with their adult children, because if we're sitting here and we're totally fine, we're not facing post-retirement. We're not facing post-retirement where healthcare is becoming somewhat more important to us. Mm-hmm. And it's becoming more prevalent in our lives. Like I can't and got to go to the doctor twice a week, those types of things. That life is coming. It is really hard to face those discussions.
And nobody wants to have a morbid conversation like that with somebody they love.
Horribly morbid.
Nobody. Right.
Nobody. It's like,
yeah, it's okay. You're never going anywhere. Where 20 years from now, you are now, and here we are. So
exactly.
Why didn't we talk about this for the last however long?
I would say to folks, there's some white labeled things to keep in mind. You don't have to get way deep into it, and you don't have to have a whole lot of it, but you have to understand if you're going to be able to afford an assisted living, mm-hmm. which is to the tune of, $5,000 to $12,000 a month. Or are you going to be able to have private duty help in your house, which can run you, if they're awake 24/7, $250,000 a year. Or are you going to be on this side where you have less financial resources, may qualify for Medicaid, and may need to live in a nursing home for the rest of your life. So understanding where your finances put you for this post-retirement space, that is a very hard conversation to have, but at least people should be thinking about that. Like, am I going to have enough money to not have to, if my kids want to have them move in with me, great.
Right. Or have enough money to not have that choice made for me at the time.
Exactly. I mean, one of the things that I always hear and I think about a lot is I once asked one of my mentors years ago when I was a resident, I was like, what is the number one reason that people move to assisted livings if there's a married couple? And they say incontinence. Once somebody becomes incontinent, it becomes really hard for that caregiving relationship to continue with just like a wife taking care of her husband or a husband taking care of her wife. Then you start needing stuff. You suddenly need continence supplies and someone to help with that. That can be messy and there's some dignity loss and all of that. I mean, there's a whole world out there. So to your question, which is how can we educate people? I think people have to start thinking realistically, like, I might need X amount of dollars to pay for these things. And when the choice for Medicare comes up, I'm probably going to have to pay $5,000 a year for health insurance moving forward, and possibly more if there's things that I have that Medicare won't cover.
Right.
And being really realistic about that, not kind of burying one's head in the sand, because once you're not working anymore and you're in fixed income, all these things become very real. So people do need to think about saving and having the conversations about saving. or tell your kids to all go into finance and then they can just pay for all of it.
Right. Or just say, hey, you realize you're going to be the one taking care of me if we don't have this plan.
Exactly.
Speaking
Totally.
of incontinence, we don't need that.
We
So
don't want
like,
that. No,
no.
exactly.
Yeah, it's interesting that you say that because I've got friends experiencing that currently. And it's difficult, and it's not so much difficult in the actual act or the physical act of, cleaning or taking care of, or because you love the person. It's difficult emotionally, and it's stressful, and it causes anxiety, all of the other things that you're just like, oh God. At the end of the day, I just, I love this person with all my heart, and I would lay down on train tracks for them, but I'm just wiped, and you can't do anything else. So it affects your life just as much as it is affecting theirs, but in way different ways, and potentially very negatively.
Yeah. I think it's interesting, just in this one conversation, we've gone from like high level C-suite conversations about how to navigate the health system down to incontinence. But I'm just going to say this, that is the missing vector, is people understanding like way up here, making lots of decisions, health systems making lots of decisions. But ultimately, it's what happens here at the ground level, what I call the last mile. How to connect that high level thinking with last mile thinking is ultimately how we're going to succeed in terms of keeping costs managed and helping people understand how to navigate that plinko, that as things bounce around, like how do we get from the people who are doing things at the very like ground level, having to figure out how to get incontinence supplies, how do we make sure that the folks who are making decisions at a very high level C-suite understand those aren't paid for by Medicare.
Right.
You know what I mean? Like even that. So it all ties together somehow. But yeah.
Very much so. And it sounds like, even from this conversation, but your podcast is that Simon and Garfunkel-esque bridge over troubled waters throughout the Medicare landscape. More Simon than Garfunkel. Nobody wants to be Garfunkel, but I might have to edit that out. But even so, this has been an absolute pleasure. And what I would love to do is continue to have you on the show. There's a lot more that I'd like to cover with you. All of that middle ground would be just an absolute blast to speak with you. It's been good hanging out with you in general as well.
That was so fun. Thank you for having me.
Thanks for being on the show, Dr. Schiffman. I appreciate it.